Welcome to the inaugural Collaborative Group of the Americas for Inherited Gastrointestinal Cancer podcast series. This series is presented by the CGA Education Committee. This year's series will focus on the multidisciplinary, patient-centered approach to management of Lynch Syndrome. The aim of this series is to hear from experts about how they counsel their patients on cancer risk reduction strategies in Lynch Syndrome. Welcome back. My name is Dr. Swati Patel from the University of Colorado, and I'll be hosting today's podcast. Remember, the content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or another qualified health provider with any questions you may have regarding a medical condition. We're excited to continue the conversation with Dr. Sonia Kupfer, Director of the Gastrointestinal Cancer Risk and Prevention Clinic at the University of Chicago and our 2017 President of the CGA. We're going to continue the discussion regarding Lynch Syndrome and the risks associated with Lynch Syndrome. And, one of the cancers that even among patients in the general population that is feared is pancreatic cancer, which we know can have an increased risk in Lynch syndrome. Is there any recommendation to do routine screening for pancreatic cancer? And how do you talk to your patients about that?
Yeah, so this is definitely a controversial area in general for individuals who are at higher risk for pancreatic cancer, specifically for I use family history as a guide, so if they have a first-degree relative with pancreatic cancer and carry a mutation in one of the mismatch repair genes, then I will recommend what's right now considered sort of the recommended approach or the standard. I don't even want to say standard because there's no standard, but perhaps the best approach right now for screening for pancreatic cancer, which is an endoscopic ultrasound alternating with an MRI that specifically looks at the pancreatic duct called an MRCP. And we generally start at age 50 or 10 years earlier from the youngest pancreatic cancer in the family. I think for pancreatic cancer in Lynch syndrome, I don't have that many families where that is the case, and we will often pair the endoscopic ultrasound with their upper endoscopy screening, and so that nicely sort of fits in with what we would do anyway for the upper GI tract. But here too, there's limited data on the effectiveness of this, specifically in Lynch syndrome, but also generally in high-risk populations. So also an emerging field, an area where I think having additional biomarkers would be of great use, especially because, as we all know, these cancers grow sort of silently and then present at later stages. So if we could find some way to risk stratify even those at higher risk, I think it would be very beneficial.
We certainly will be we're excited to spend a lot more time on the GYN cancers associated with Lynch in future podcasts. But as somebody who, like you said, oftentimes is the first person to counsel a patient about their Lynch syndrome diagnosis, what do you recommend in terms of prophylactic surgery, timing of the surgery, whether to do a hysterectomy with oophorectomy? Does genotype ever influence your recommendations?
Yeah, so, in general, I think that when we talk to women, often we're meeting them when they're, young and have maybe not had their family yet that they desire. And so we mention this, we say, this will be an option after your childbearing years. But at that moment, we talk about the fact that, we have other ways of doing screening specifically for endometrial cancer. And I will do endometrial biopsies in young women, usually starting around the age of 30, or again, sort of modifying that based on their family history. What we've moved to for the endometrial biopsies, because these are typically done in a gynecologist's office, and there can be discomfort associated with them. So what we've been trying to do here, and it takes some coordination, but we combine it with the colonoscopy. So our gynecologist will come into the endoscopy suite, and when the patient is sedated, we'll perform the endometrial biopsy either before or after the colonoscopy. And in that way, we're hoping to kind of one-stop shop, get everything done, and try to make it as comfortable as possible. So many young women have really appreciated that. Now, it's not possible everywhere, but it's something that if it can be coordinated, patients really appreciate it. Then when we're getting, after their childbearing years, so we're talking in their 40s, then we have the conversation about hysterectomy and oophorectomy. And many will, take us up on it. They choose to do that. There are concerns about, menopause, early menopause, and symptoms related to that. And we of course work very closely with our gynecology group when making these decisions. And I will recommend that they have the hysterectomy and oophorectomy at the same time, mostly because just like pancreatic cancer, ovarian cancer, we just don't have very effective screening for. And so I think to risk reduce, even if it's a small risk, is important for ovarian cancer. So that again, this is done as a team effort with our gynecologist, and I would say that many patients, especially those with strong family histories of endometrial cancer, will proceed with this, and just in terms of genotype-phenotype correlations, this often will be families with MSH6 mutations, but we talk to all our patients about it. I think with the PMS2 mutation carriers, this becomes an interesting conversation because, again, their risks are lower, although if you look at the current NCCN guidelines, they do have a lifetime risk of 15%. So that's on par with, perhaps MSH6 and MLH1 and SH2. So we still have that conversation and are really hopeful that we'll have more data in this area so that we can make more personalized and precise recommendations.
Absolutely, and it's incredible that you're able to offer a joint appointment with your gynecologist. That's something that we should all try to aspire to, for patient-centered care.
Yeah, it really takes a team effort, and I work with a really fantastic gynecologist who will drop what she's doing and run over with her little bag and get the biopsy done. So it's been really a wonderful approach to, and I think our patients appreciate it too.
That sounds like a great collaboration. So if we look at the NCCN table that you're referring to, or if a patient Googles Lynch syndrome, there's a whole long list of potential Lynch-associated cancers. In general, is there kind of a checklist of things that you review with your patients to potentially screen for? You mentioned kind of routine blood work to evaluate for anemia or microcytosis. Are there other things in that bundle that you recommend routinely for your patients?
Yeah, absolutely. So I always, I have sort of in our electronic health record kind of a checklist that I've developed from various guidelines, and go through that with the patients. The main things, obviously, beyond colonoscopy, which we've talked about, endometrial screening for women, routine blood work. I do recommend a blood count every year, and then a comprehensive metabolic panel. Again, there's not much data, but there's also not much downside to doing that. And if we potentially could pick something up early, that would be helpful. I also recommend yearly skin exams. Those are, good in general for, early identification of skin cancers, and specifically those associated with Lynch syndrome. In terms of urinalysis or urine cytology, there's really, again, not very much supportive data. And if you talk to urologists or individuals who take care of patients with urothelial cancers, they'll say those things don't work. And so that being said, I will do a yearly urinalysis. I think it's a cheap test, and if there is blood identified, then that is at least something that will prompt a referral to our high-risk urology group here. I know of people, though, who also work in high-risk clinics, and they say, we've stopped doing urinalysis because there were either, too many false positives, we were sending too many people that ended up getting procedures, and there was just nothing there. So the individual I would refer directly to high-risk urology would be those who, obviously have a personal history of any urothelial cancers, but also a family history. And those individuals, there are different screening tests that are done. So there are CT scans specific for the urinary tract, or cystoscopy as my colleagues see fit. But for me, it's blood count, comprehensive metabolic panel, skin exam, urinalysis, and then colonoscopy and endometrial biopsy, or then hysterectomy. And then, as I mentioned, in specific situations, if there's a family history of pancreatic cancer, then we'll talk about pancreatic cancer screening as well.
Quite the to-do list. One of the most common questions that patients come in, they say, gosh, I can't change my genetics, at least yet, but what can I do that's under my control that might impact my risk? Can you talk about medications, diet, lifestyle?
Yeah, I totally agree. This is one of the major questions we get during our visits with patients, any patient who has an increased risk of cancer, and definitely in Lynch syndrome. Anyone who's been following the field has followed the aspirin story in Lynch syndrome, and Sir John Burns' studies of aspirin, which really were, in my mind, very heroic studies that gave us really, the data that aspirin probably is chemopreventative in Lynch syndrome. Now, the dose that was used was a high dose, 600 milligrams, and so I'm currently not recommending patients take 600 milligrams, although it's interesting that in that study there were no differences between those who got 600 milligrams of aspirin and those who did not in terms of, any adverse events, bleeding, etc. But at this point, my feeling is, if the patient can tolerate a full dose aspirin, so that's 325 milligrams, I'll have them take that. If for some reason they have any kind of side effects, we'll go down to 81 milligrams. And there is an ongoing study right now that hopefully in time will tell us what is the appropriate dose specifically in Lynch syndrome. So aspirin is definitely part of the conversation. I think that there's certainly data in colon cancer in general for vitamin D being helpful, and I think there's potentially limited downsides to recommending vitamin D, especially in northern climates where we don't have very much sun exposure, especially with our long winters. So I will recommend that they can consider vitamin D. Now there too, we don't know what the best dose is, and so that's something that still needs to be established. Otherwise, in terms of other diet, lifestyle factors, of course we say, being healthy is very important and probably impacts, risk even in individuals who carry genetic mutations. So we talk about exercise, we talk about eating fresh fruits and vegetables, maintaining a normal body mass index. So there have been studies from the Netherlands that have looked at how obesity affects adenomas in Lynch syndrome, and interestingly the risk was higher in men who were obese they had an increased risk of developing adenomas. And that could be actually reversed by taking aspirin. So there are all these interactions between all of these factors. I think the other thing, that has gotten some attention in the last few years has been the effect of red meat and processed meat. And so, there's certainly not studies that have specifically looked at those factors in Lynch syndrome, but, we talk about moderation, always moderation, and certainly if they're smoking, we recommend that they quit smoking. So, the things your mom told you were good probably are good to follow for everybody, but certainly in Lynch syndrome. I will say, though, that, you mentioned this, that, the gene here, we're talking about lifetime risks of, 50%. So, how much you can modify that with diet, exercise, and lifestyle, it may be some, but certainly is not going to reduce that down to the general population risk. So I also, sort of want to temper that for patients and say, you can do everything right and cancer may still develop, and that's why, we have you on these screening programs. So just, to sort of make them feel like, even if I do everything right, it's not their fault, basically. So there's, patients want to have control of certain things, and there's just certain things that the genetic mutation, is going to put them at risk, and that's where our screening programs come in.
Absolutely. Sounds like it's really helpful to contextualize the magnitude of risk reduction associated with each thing, and perhaps diet, lifestyle may toggle the risk a little bit above or below the baseline, but really the biggest contributor to a Lynch syndrome patient's risk is their genetic diathesis.
Absolutely, yep.
So thank you so much for all the time that you've spent with us today reviewing all of the cancer risks and how you talk to your patients about these risks. In general, what are the challenges that you face when trying to implement these screening programs with patients, and how have you had success overcoming those?
Yeah, so, I think in general, Lynch patients are coming from families where there's been a long history of cancers in the family, and so for the most part, I have such motivated and engaged patients that are willing to do anything that I tell them in terms of screening, and so. But there are certainly challenging discussions. So, for example, I had mentioned this earlier about my PMS2 mutation carrier in the 70s. The discussion of when to stop. The other difficulty that I see in where I practice, which is on the south side of Chicago, is lack of health insurance. And, so patients will they be able to get screened? Where will they be able to be screened? Will they follow up with the screening? So, getting the screening can be a challenge. I think another area that I struggle with is helping patients to track their screening and if they're up to date. So we have been, we often rely on the patient to say, it's a year, I have to come back. And so we've been trying to implement systems where we send reminder letters, hey, you're due for this, but it's challenging to keep up with every individual person's specific screening regimen. So, having better tools for that. I know that there are certain apps that have been in development to help with this kind of a thing, but that can also often be a challenge just in keeping up with the screening.
Absolutely.
And then something that recently came up is, how to, is it safe to continue screening? So I recently had an older patient with an MLH1 mutation who herself had endometrial cancer, had radiation, post-surgical changes, and so her colonoscopy is incredibly difficult. And in fact, she recently had a procedure by another physician, and it led to a perforation that was, colonic perforation that was dealt with right at the moment, so there was nothing, no bad outcome. But it then brought up the question, do we continue screening? How do we do screening? Do we have alternatives, like can we use CT colonography? Can we use fecal-based testing? Can we stop screening because she's now, in her later 70s? So those are the kinds of, some of the challenging discussions that I've recently had, and I'm sure there's many more, including, do I have to do all of this? Do I have to come back every year? So I think having a good relationship with the patient and, making this a team effort with them is incredibly important.
Yeah, you mentioned the patients that you have who don't have insurance. What about some of these other strategies that you've talked about that are maybe slightly outside the guidelines, for instance, with pancreatic cancer screening or deeper small bowel screening? Do you encounter difficulties even in those patients who have insurance to get something like that paid for?
Yeah, thus far, I would say, knock on wood, it hasn't been a problem. There have. So I'm thinking about one patient in particular, although she had kind of minimal insurance and required a lot of pre-authorization, and it had to come through her primary care physician. And so she was having some symptoms, some small bowel symptoms, and we wanted to get imaging, and that was becoming a big challenge to get that covered. So there certainly are those situations. Thus far, pancreatic cancer screening in general in my high-risk patients has not been a problem, but I definitely can see how an insurance company would question why they need an MRI every other year, or why they need an endoscopic ultrasound every other year. This is where we're a team with the patient. We advocate for them. I send many letters explaining the importance of these different tests. Thus far, it hasn't been, it's not like every patient I have to do this for, so, but it may be coming.
Sure. Well, again, Dr. Kupfer, thank you so much. Really appreciate you taking the time to delve into the details with us today. It sounds like one of the most cornerstone helpful practices you have are the multidisciplinary relationships you've built with all the different specialists that take care of Lynch syndrome patients with you. If there's a takeaway, at least from our conversation, that I hear is that this is the beginning of the discussion. Though you may have this in-depth discussion with a patient when you first meet them, this is a long-standing relationship that will evolve over time. I'd love to hear any final thoughts, any final words of wisdom that we can all benefit from.
Yeah, I just was talking to a patient yesterday about this who was facing, surgical decision-making, and, I said, as I've been mentioning, this is, we're all on a team. There's co-captains, so the patient is a captain, and then I like to identify myself just so that they have kind of the person who they can look to if they're meeting with the surgeon, and then they're meeting with the oncologist, and there's so many different faces and so many different individuals. I want them to have one person to turn to. So I try to set that out at the beginning of our relationship when I'm first meeting them. And, we also see patients, and I'm sure this is for others even more of a challenge, is that, your patient might live hundreds of miles away from your center, and so how to maintain that relationship and that team approach. And there have certainly been cases where patients have gotten lost to follow-up, and, they come back and they've been anemic for a year and nothing has happened. So I always tell them, if anything's going on and anything that you're concerned about, just touch base with me so that I know what's going on and I can work with your local physicians. And, having that set out from the beginning, to me, just helps the patient to know who can I turn to because, as you've probably heard, sometimes these patients know much more about their own syndrome than even their physicians do. And so it can be, very challenging for them. And that's where I think that partnership and that relationship is so important. And I love it. I mean, that's why I do what I do, is I love those relationships. I love seeing these multiple generations of families and, sort of guiding them together through this process.
That's incredible. Your patients and the families of your patients are so lucky to have you, as is the CGA membership. So thank you so much for taking the time.
Yeah, no problem. No problem. I'll just say, too, that, I think, as I mentioned, where I practice, we face, additional challenges here sometimes with, with populations that really are underserved or just don't have health insurance, and that adds additional challenges where you have comorbidities. So I have a Lynch family where both of the sons who are affected have schizophrenia, so we're dealing with how to have them understand what's going on, just getting them to their appointments. I've figured out how to get transportation so they get here. How do they pay for a bowel preparation? I have a patient who just can't even afford, basic copay for a bowel preparation. And then one patient who has no phone. So I have to call the landlord, and he has to find this patient, and so the challenges are steep. But again, getting back to the root of sort of that relationship, and even if there are hurdles, that you continue to try to work to get over those hurdles, and I've grown very close to my patients here on the south side of Chicago, and we've done radio programs together and community outreach, and it's been really, really rewarding.
That's incredible. That's incredible to hear. Again, thank you so much for your time today.
Thank you.
Please stay tuned for our next podcast featuring Dr. Leslie Garrett, a gynecologic oncologist at the Beth Israel Deaconess Medical Center. She'll be discussing the approach to family planning decisions, as well as the management of GYN cancer risk in Lynch Syndrome. Please follow us on Twitter at CGA-IGC. If you value this type of educational content, please consider becoming a member of the Collaborative Group of the Americas on Inherited GI Cancer Syndromes. You can get details from our website at www.cgaicc.com.